Welcome, everyone. Thank you for being with us tonight. I'm Katira Noviello Kapoor, and I am the Senior Director of Health Promotion, Wellness, and Athletics here at the 92nd Street Y. Thank you for joining us this evening for a special Spark Your Health discussion with Dr. Ellen Scherl and Dr. Lou Bridges on the gut and joint health connection, how to manage IBD and arthritis. We look forward to learning about the links between both conditions, what we know presently to be best practice in treatments, and how the doctors' teams continually unlock new critical findings to help alleviate symptoms. We hope to see you for our upcoming Spark Your Health talks, such as Cassie Holmes on November 3rd, discussing the meaning behind her new book, Happier Hour, and how we can create more time for joy in our lives. We will leave 10 to 15 minutes at the end of the event for Q&A, so please feel free to be entering questions into the chat throughout the duration of the event. Now I look forward to introducing our speakers this evening, so bear with me while I bring them onto the stage here, the virtual stage. Okay, welcome, welcome. So, Dr. Lou Bridges has served as Physician-in-Chief and Chair of the Department of Medicine at Hospital for Special Surgery and Chief of the Division of Rheumatology at HSS and at Weill Cornell Medical College since 2020. Dr. Bridges is the immediate past president of the Rheumatology Research Foundation and a former member of the Executive Committee's Board of Directors of the American College of Rheumatology. He received the UAB Department of Medicine's Max Cooper Award for Research Excellence and the UAB School of Public Health's Sam Brownbridge Builder Award. He is former co-editor of Arthritis and Rheumatology and past chair of the NIH Arthritis, Musculoskeletal, and Skin Study section. His research focus is rheumatoid arthritis susceptibility, autoantibodies, and biomarkers of treatment response, and he has authored more than 170 manuscripts. Welcome, Dr. Bridges.
Thank you.
Very welcome. And then Dr. Ellen Scherl, welcome. Dr. Ellen Scherl is a professor of clinical medicine and the Jill Roberts Professor of Inflammatory Bowel Disease at Weill Cornell Medical College, New York Presbyterian Hospital, where she is the research director and founding director of the Jill Roberts Inflammatory Bowel Disease Center. Dr. Scherl is a world-renowned expert in inflammatory bowel disease, specializing in Crohn's disease and ulcerative colitis. Dr. Scherl is committed to advancing the science of IBD and translating laboratory discoveries into improving patients' lives. Castle Connolly has consistently honored Dr. Scherl as one of America's top doctors. She was also the 2020 honoree for the CCF Humanitarian of the Year Award and received the 2012 CCFA Woman of the Year Award for Outstanding Women in Science. So welcome, Dr. Scherl. We are so happy to have you both here with us tonight, and we'll go ahead and start with Dr. Scherl's presentation.
Thank you, Katira. So I want to thank Katira Kapoor Noviello for coordinating this program and the Benenson family for introducing me to the 92nd Street Y and Stacy Eisler, and of course to Dr. Randy Longman for his commitment to understanding and researching IBD and arthritis, and for inviting me to initially present this lecture at Hospital for Special Surgery with Lou Bridges and his team. Let's see, share the screen. I'm going to be talking about reverse IBD, the other arthritis. And what we know is that we want to find therapies that reverse the natural progression of disease. In 1950, Philip Hench actually received the Nobel Prize for steroids, which were thought to change the disease process of rheumatoid arthritis and other inflammatory disorders such as IBD. But within 10 years, we realized that that is not true. And so steroids don't do anything to modify the disease. What we're going to discuss is the natural history and pathogenesis of inflammatory bowel disease, moving from the era of symptom control, which was largely dictated by steroids, and into the era of disease modification, which is where we are now, and using biomarkers to really determine inflammatory from non-inflammatory symptoms, and then T cell and other future directions for stem cells for therapy. So IBD, like arthritis, is a chronic, lifelong disease. It's sapping, interruptive, and it's systemic. It's aggressive, unpredictable, and results in tissue damage. Same thing for both treatment diseases. We want lifelong maintenance therapies that are global, systemic, strike early, and result in tissue healing to prevent tissue damage. So I want to present a young woman who came to us about a year and a half of refractory Crohn's ileitis, arthritis, and enodosum. She had been in excellent health until the summer, traveled to France after 1 month, developed new onset of monoarticular arthritis, unresponsive to non-steroidal anti-inflammatories and aspirin, followed by diarrhea. 2 months later, she had an upper GI small bowel series CT scan that shows this inflammatory, sticky, thickened, narrowed ileum that is Crohn's disease. From an endoscopic standpoint, you can see the normal blood vessels, arborization, and then as you pass into the valve between the colon and the small intestine, again, you see thickening, swelling, and inflammation. This is Crohn's disease as he initially described it. We now understand that it can affect, this inflammation can affect anywhere from the mouth to the anus, and that it has extraintestinal manifestations. It's important to recognize that there are inflammatory symptoms and non-inflammatory symptoms. We want to focus on identifying inflammatory symptoms and controlling inflammation. The course of this uncontrolled inflammation in IBD varies over time in different patients, but the most important takeaway is that when you start out with an inflammatory disorder, if you do not intervene early, the inflammation will go on to stricture and fistulize, and that ultimately leads to loss of function. Inflammation in the joints leads to loss of function. You can't walk. In the GI tract, you can't absorb, you get nauseated, vomiting, and you have anemia and many other symptoms such as weight loss and malnutrition. We do define moderate to severe disease for both ulcerative colitis and Crohn's disease, but we still think about inflammatory bowel disease as ulcerative colitis and Crohn's, but we're beginning to broaden the definition. If we look at Crohn's, as we said, transmural, it affects all 3 layers of the walls of the colon and intestine, and can affect anywhere from the mouth to the anus, whereas ulcerative colitis tends to stay in the colon. It's a global disease, increasing prevalence, increasing incidence. Who gets it? Or maybe we should ask who doesn't get it. Everybody's GI tract has inflammation. That's the natural state of the gut, but it's controlled inflammation. The purpose of inflammation is to limit infection. No matter how we try to define the elegance of the intestine, which it is, it's still a bag of bugs, and inflammation is supposed to protect the inflammation for the bugs from getting into the deeper layers and causing chronic inflammation. In Crohn's disease and ulcerative colitis, for reasons we don't fully understand, the inflammation doesn't stop. But we think that there's a genetic predisposition and then an epigenetic or environmental change, the climate change, the way we eat, that results in this dysregulated ongoing immunoinflammatory defect. Antibiotics sometimes make things worse, sometimes better. The diet, processed food, high sugars, carbohydrates, and fats definitely drive inflammation. Acute infections sometimes precipitate this. Non-steroidals, and as in our patient, precipitate inflammation. Smoking is protective in ulcerative colitis, but worsens Crohn's disease. Stress makes nothing better, but it doesn't cause the disease. The take home here is that if you don't have bacteria, no matter what your genetic disposition is, you don't have inflammation. So no bacteria, no inflammation. And here is a sort of Star Wars cascade. The antigen is the infection, the bacteria, the virome, whatever it is that's triggering this inflammatory response of lymphocytes and immune cells and pouring out inflammatory proteins that cause this chronic inflammation. The role of bacteria, and here you can see normal controls, and then in Crohn's disease, this adherent enterobacteria, enteroadherent and invasive bacteria. We've done work with our colleagues, Kenny Simpson and all, up at the Ithaca campus to look at the metabolome that actually drives these bacteria that are pro-inflammatory. So if you want to change your microbiome from pro-inflammatory to anti-inflammatory, you have to look at what you're feeding it and what you're eating. There is one cell layer, the epithelial cell layer, that separates the bacteria in the lumen of the gut from the deeper tissues. And this is what's responsible. Leaky gut will result in this ongoing inflammation. So it's a dysregulated immune response. We're going to focus a little bit on the interleukin-23 and Th17 pathway as it mediates microbial defenses and results in intestinal inflammation. Also, multiple JAK-STAT components drive and implicated are in the this pathway, and we have now therapies that are targeted for all of these molecules. A new way of looking at inflammatory bowel disease and arguably arthritis is to look not at the organ itself, but at the cytokine signatures. And here you can see that IBD is not necessarily responsive to IL-17 pathway. Spondyloarthropathy is not necessarily responsive to IL-23, which actually IBD is exquisitely sensitive to. Peripheral arthritis, monoarticular arthritis, is one of the ways that arthritis manifests in Crohn's and ulcerative colitis. Here is a slide from Randy Longman depicting Van Gogh's conception of arthritis. Randy has looked at this in terms of the microbial signatures and specifically Prevotella in the microbiome in rheumatoid arthritis. And then he's gone on to look at patients with IBD with and without extraintestinal manifestations and has looked at the microbial signatures here as well. And he's looked at sulfasalazine in these patients. But come back to the way that inflammatory bowel and Crohn's disease presents. It's inflammatory and then progresses over time to stenotic and fistulizing. There's a Vienna and Montreal classification that goes on anatomy and behavior. We have not yet added extraintestinal manifestations that are so critical. We are, as I said, moving out of a 20th century nomenclature into a 21st century classification that takes into extraintestinal manifestations, which are so important. I would refer everybody to the April issue of Gastroenterology that talks about the importance of disease modification in inflammatory bowel disease. So we moved away from the era of symptoms, controlling inflammatory symptoms and also identifying inflammatory from non-inflammatory, celiac, gas, bloat from lactose intolerance, bacterial overgrowth, bile salt, diarrhea, pancreatitis, alcohol. But basically, mesalamine, steroids, and 6-MPA-azathioprine basically address symptoms, not change the disease course. And pre-biologic, there was nothing to prevent the loss of function over time. What really happened in this young patient, 17 years of age, is that she was treated with 6 weeks of high-dose prednisone and then put on 6 months of Pentasa, which does not change the course and is not steroid sparing. So when she presented to us, by the time she did, she had lost 20 pounds, was Cushingoid, had enodosum, and severe crippling monoarticular arthritis. So the treatment options now, I think, would be the anti-IL-12/23 pathway with ustekinumab, risankizumab, and soon to be approved guselkumab. There's still a role for early intervention of infliximab and the anti-TNF, but I would make a case for using the non-anti-TNF in a patient like this with moderate to severe. The anti-IL-23 are less immunogenic, don't lose response, great persistence. And also some of the novel agents such as ozanimod, which you'll hear, trap those lymphocytes in the lymph nodes and are great for first-line therapy. Again, IBD is a lifelong disease. Steroids are not the best medication to change the natural history. And we should be aware that some patients with just isolated ileal disease can present with a very aggressive course, as this patient did. The AGA position paper and the European societies do recommend a short course of steroids being tapered aggressively over a 3 to 4 month period while you institute effective disease-modifying medications for Crohn's. And here again, you can see at the end of a year, 2/3 of patients who are started on steroids for Crohn's are either steroid dependent or steroid refractory in the OR. So enter into the modification of disease infliximab and the anti-TNFs, 2014 vedolizumab, gut-specific alpha-4 beta-7, and then the anti-IL-12/23 ustekinumab and IL-23 risankizumab, soon to be followed by guselkumab, Stelara, and Tremfya, respectively. Tofacitinib is a JAK inhibitor, JAK1 and 5. Selective JAK inhibitors are upadacitinib, now recently approved for ulcerative colitis, severe, moderate to severe, incredibly effective with the very low placebo rates as we saw in the initial infliximab data. So very effective. The ozanimod is the synuclein receptor modulator that works for ulcerative colitis now, but soon should be approved for Crohn's. And here's again, just a depiction of the gut luminal bacteria, the epithelial cell, and then all the inflammation that occurs through dendritic cell and lymphocyte activation. If the lymphocytes do not get delivered from the blood vessels down below into the gut tissue, then you can avoid inflammation in the gut. And that's where vedolizumab and some of the etrolizumab MAdCAM inhibitors come into play, and where ozanimod comes into play, where the lymphocytes are trapped in the lymph nodes, never get delivered to the tissue. So early intervention changes the progression of Crohn's disease favorably. If you intervene too late, you're not going to reverse the ongoing damage. But if the patient goes into surgery, you can prevent it by post-op therapy. So divining natural history of IBD has proven very helpful in selecting therapies, and defining symptoms that are due to inflammation as opposed to non-inflammation is critical in our treatment using effective therapies. This is the 1995 study that really introduced infliximab in this forum, and you can see the deep break-like inflammations, like a terrible sunburn on the inside. 4 weeks later, there's mucosal healing, and this now guides our therapy. Not good enough just to treat the symptoms. We need to achieve mucosal healing. TNF works for not only ulcerative colitis and Crohn's, but rheumatoid arthritis, psoriatic, psoriasis, and ankylosing spondylitis. The mechanism of action is similar in both disease, and in the rheumatologic study, the best study, initial combination with infliximab was better than any monotherapy. So we in the IBD space now have 2 head-to-head trials. The Varsity trial compared vedolizumab Entyvio to adalimumab Humira in moderate to severe ulcerative colitis, showing that vedolizumab was superior. The CView is the first head-to-head trial in moderate to severe Crohn's, comparing ustekinumab and anti-IL-12/23 Stelara with adalimumab Humira, showing that at the end, more than 60% were in steroid-free remission at the end of a year, but that the ustekinumab Stelara arm actually lasted longer, greater persistence, less immunogenicity, and less injection site reactions. So the critical point here is that the medication, the anti-IL-23 class, is less immunogenic, does not cause infection, not really associated with lymphoma risk. You don't need combination therapy, and it should be used as first line. That is my approach. The SONIC trial looked at infliximab with or without azathioprine and azathioprine alone, showing that both were better than azathioprine alone. And it furthermore showed that if you didn't have an elevated marker of inflammation with either a C-reactive protein or fecal calprotectin, that using these effective medicines were not going to work. So again, it moved us to define symptoms, whether they're inflammatory or not. And here's the impressive clinical data at the end of 52 weeks. So really, most of these patients were steroid-free at the end of a year. Again, we've talked about the persistence with the anti-IL-12/23 class, which I think positions it as a first-line therapy before anti-TNF. And all of the anti-TNF therapies, if the patients are bio-naive, they do much better. Whereas with these newer biologics and small molecules, if you use them first and then go on to an anti-TNF, the anti-TNF introduction still acts as though they were first line. So I think we should think about where our anti-TNF therapies are. The burden of inflammatory bowel disease in the United States and around the world is increasing, and yet more than 85 to 90% of patients are not treated with effective treatment. This is the Truven database. 15% of patients in Crohn's are getting biologics, and less than 10%, 5% with ulcerative colitis. So we need to individualize therapy. We need to recognize inflammatory from non-inflammatory symptoms, and we need to even understand, once we define them as inflammatory symptoms, that even those coming under control is not good enough. We need mucosal healing, at least by 50% improvement. The clinical trials look for complete mucosal healing, very strict endpoints. But look at these new therapies. We've got the new anti-TNF, but more importantly, the JAK inhibitors, upadacitinib, Rinvoq, ozanimod, Cebosia, and we have vedolizumab and other agents that are coming down. Risankizumab, which is now known as Skyrizi, Tremfya will be coming in. We want to use these early on. And so the question is, with all these novel effective therapies that are disease modifying, is it going to be something new, or is it going to be more of the same, more steroids? So we're hoping for policy changes that will allow us to increase the utilization in these moderate to severe therapy. The goals of therapy, as we've said, are of course to control symptoms, but more importantly, to control the actual inflammation and to intervene early, within 2 to 2.5 years from the time of diagnosis. We need to use markers of inflammation, such as fecal calprotectin, C-reactive protein, and endoscopy. And those are our goals to keep the patients in remission. A lot of work now being done in stem cells, which is fascinating, autologous T cell transfer. So we're moving into a cellular and molecular direction. And here are these cytokine signatures that define the diseases rather than organ specific, what inflammatory microbiome, metabolome, and cytokine, as well as cellular pathways are driving the inflammation. And again, coming back to the need to define these therapies and to recognize ileal disease as aggressive and extraintestinal manifestation as a whole nother aspect of aggressive disease. We want to optimize and engage the patients, and we want to avoid long-term inflammation and damage of the gut. And so in summary, reverse IBD, the other arthritis, and spondyloarthropathy is treated very much like arthritis. We need to recognize that IL-17 works better for the arthritides, and the IL-23s are exquisitely sensitive for both Crohn's disease and ulcerative colitis. We want to redefine extraintestinal manifestations to recognize the severity of the disease. And if we've said it once, we've said it many times, we want disease modification. And as gastroenterologists, rheumatologists, nutritionists, physiatrists, and patients living with this disease, these diseases, we can work together and learn from each other. In 1950, Philip Helm said that the goal is to find a therapy that provides sound basis for much hope. In 2022, going to 2023, in the next decade, it still sounds like a good idea. Early intervention with individualized novel steroid-sparing therapies that can be positioned first line without immunogenicity, without a black box, is the way we should be thinking about this, with a multidisciplinary collaboration in food and exercise as a form of medicine at the right time. Again, these are suggested readings and links. Thank you very much.
All right, and Dr. Liu, the floor is yours.
Okay, can everybody see my screen? So, Ellen, that was a tour de force. That was really wonderful. Thank you so much. So I'm going to take a little bit of a different approach and first just tell you what we consider IBD associated arthritis part of. So the way that we have traditionally in rheumatology thought about inflammatory types of arthritis are the rheumatoid arthritis, which is characterized by autoantibodies, and rheumatoid factor is one of them. Another one is called anti-CCP antibody. But then we have a category of arthritis known as seronegative spondyloarthropathy. So seronegative means serum negative for the autoantibodies that I told you about, rheumatoid factor, CCP. Spondylo means spine, arthro means joint, pathology is abnormality. So it's a very descriptive name for this category of diseases, seronegative spondyloarthropathies. And it's a family of diseases, and it includes the traditional ankylosing spondylitis, which affects the spine predominantly, but can also affect the eye, the heart, and other organs. Psoriatic arthritis, which psoriasis, a certain proportion of patients with psoriasis will go on to have psoriatic arthritis, or in some cases develop psoriatic arthritis before they develop psoriasis. The inflammatory bowel disease that Ellen so elegantly described, Crohn's disease, ulcerative colitis. There is an inflammatory type of arthritis that goes along with these diseases. Reiter's syndrome is the old term for this. Unfortunately, a lot of people who've described these syndromes turned out to have be Nazi sympathizers. So we no longer call it Reiter's syndrome. We call it reactive arthritis, and this is a syndrome of oral ulcers, arthritis, and related syndrome, related findings after a dysentery, usually with a bacteria, or after a sexually transmitted disease. And it's a chronic form of arthritis. And then Undifferentiated spondyloarthritis means that there's spine disease that looks like one of these, but it doesn't really meet criteria for any of the four listed above. So shown here are some of the extra intestinal. Let me see, can everybody see the top of that? Maybe not. But the extra articular, meaning outside the joint, outside the gut, manifestations of inflammatory bowel disease. So you can see here in the green are the more common ones, and then the blue are the more rare ones. But you can see that it's common to have uveitis, which is inflammation of a portion of the eye, aphthostomatitis, or sores in the mouth, periodontitis, inflammation of the gums, which is not always due necessarily to just not brushing or not flossing. Axial arthritis. Axial refers to the axis, meaning the spine. Primary sclerosing cholangitis can be seen. Erythema nodosum, which the case that Ellen presented had, which is a erythematous nodules under the skin that can be seen with a variety of inflammatory and autoimmune diseases. Pyoderma gangrenosum, which is a form of cutaneous, a very angry, ugly appearing ulcerative type of rash that can be seen with inflammatory bowel disease. Thromboembolism or blood clots, and peripheral arthritis, which is different from axial, and peripheral meaning, as you might imagine, in the peripheral joints as opposed to the spine, and enthesitis, which is inflammation of the area where a tendon inserts into bone. So these are some of the common manifestations. I won't mention all the rare ones, which you can see here. But let me just summarize a little bit about the arthritis that goes along with this. So you can see here peripheral arthritis or spondylitis, which is arthritis in the spine, or sacroiliitis, which is inflammation of the sacroiliac joints. And I have some radiographs of this to show later. Can occur with some patients, not only with ulcerative colitis, but also Crohn's. The peripheral arthritis is more likely in patients with large bowel disease and in those that have more complicated GI inflammation and don't respond quickly. And then also the arthritis is more common in patients that have other extra articular involvement from their Crohn's or their UC. Enthesitis can occur. Dactylitis is of an entire digit, and I'll show some pictures of that. These are not quite as common. And then we kind of refer to different types of inflammatory of peripheral arthritis as acute remitting pauciarticular, meaning affecting only a few joints, and occurs early in disease. It commonly involves the knee and usually doesn't cause any long-term damage. And then the type 2 peripheral arthritis tends to be more chronic, has more relapses, as opposed to just a few joints. It can affect many of the joints, frequently involve some of the small joints in the hands, such as the metacarpal phalangeal joint, which is the set of joints where your fingers connect to the palm. And spondylitis more frequently affects men with IBD than it does women. Typical symptoms are characteristic of inflammatory back pain. So inflammatory back pain is pain that is prolonged stiffness and pain in the back of the buttocks in the morning or after rest, which is relieved with exercise, which is typically not what you see in degenerative arthritis or osteoarthritis, where the pain gets worse with exercise and tends to be a little bit better in the morning. So other characteristics, we do test to look for inflammation. The so-called acute phase reactants are the erythrocyte sedimentation rate, so-called SED rate, C-reactive protein called CRP. Those are the ones we most typically order. And if they're elevated, they reflect the activity of the intestinal disease, but it's difficult to say that it correlates with peripheral arthritis or spondylitis unless the GI disease, the ulcerative colitis, and Crohn's is thought to be very inactive and very well controlled, in which case it can be useful. Interestingly, there's one set of genes, and in fact, in the major histocompatibility complex, which is the most dense region of genes in the human genome, it's on chromosome 6. There's this one particular locus in this complex, so-called HLA-B27, that is very strongly associated with mostly with ankylosing spondylitis, but to some degree with the other types of seronegative or spondyloarthritis as well. And then the synovial fluids, if we were to get fluid, normally a knee joint, for example, has 1 drop of fluid. If we do get fluid out, then typically it's moderately inflammatory, not severely inflammatory, such as we see in acute gout or acute flares of rheumatoid arthritis. And then the radiographs are often giving us clues because you can see inflammation or sometimes fusion of the sacroiliac joints. So here's some pictures of some clinical manifestations. In A, you can see the right knee is swollen. There's fluid above the knee here. You can see obvious swelling in the right compared to the left. B shows enthesitis. So you can see a lot of swelling here. This is where the Achilles tendon inserts into the calcaneus or the heel bone. And this is characteristic of a seronegative spondyloarthropathy. And then C shows dactylitis. So this finger is very enlarged, very swollen. It's not just restricted to the joint, it's the entire finger. You can also see, you can't see it very well, but there's nail dystrophy, which is often a sign of seronegative spondyloarthritis as well. So here's an example of sacroiliac joints on X-ray films. So keep in mind that this joint is curved. So a couple points. This bone right here that I don't know if you can see it, but the outline here in the center of the picture is the sacrum, and on the sides, the periphery, you can see the right ilium and the left ilium. So it's hard to interpret these films sometimes because you're not looking straight on perpendicular at the joint, because the joint curves as the sacrum curves and as the ilium curves. And if you see on the right with the upper arrows, there is no sacroiliac joint. It is completely gone. So what has happened in this end stage patient with sacroiliitis is there's no joint left at all. And the sacrum and the ilium are one bone. And you can imagine that that affects your mobility of your back quite significantly. So this is an end stage result, but you can see various degrees of inflammation and joint space narrowing and erosions as the disease progresses. So I mentioned briefly HLA-B27. This gene is very interesting in that it's strongly associated with many forms of seronegative arthritis, including a form of juvenile idiopathic arthritis that looks more like adult ankylosing spondylitis, with inflammatory bowel disease, with psoriatic arthritis, with undifferentiated, as I mentioned, with reactive arthritis, ankylosing spondylitis, but also it is associated with acute anterior uveitis that doesn't always fall into one of these particular disease phenotypes as well. So how do we treat the arthritis that goes with inflammatory bowel disease? It's very common in medicine to say, and it is true, that we want to treat the underlying condition. So if we think that a patient has arthritis, which is inflammatory and is related to underlying inflammatory bowel disease, we want to treat that underlying bowel disease. And so as Dr. Sherrill mentioned, we want to use the drugs that are so effective. And we hope that by treating the inflammatory bowel disease, the arthritis will get better. The arthritis in inflammatory bowel disease generally does not destroy the joints, as we see often in rheumatoid arthritis. So the therapy is directed, a lot of it is directed at symptomatic relief, as opposed to the IBD, where we want to really wipe out the inflammation. As Dr. Sherrill said, take no prisoners, completely get rid of any inflammation, that will affect the gut. And then by doing that, it should help the joints as well. The drug choices, it's important that the rheumatologist and the gastroenterologist and the patient all discuss these things and be on the same page. We need to rely, if we see something that's secondary arthritis to the inflammatory bowel disease, as I mentioned, we will rely heavily on our collaboration with gastroenterology to really try to ablate the gut disease. There are certain medications that seem to improve both, and that's including the TNF inhibitors, some of the IL-12, IL-23 inhibitors that Dr. Sherrill referred to. The initial treatment, because we want to try to initially control the symptoms, is this, but we rapidly try to go into more treatment if the symptoms aren't alleviated. We often will use sulfasalazine. Methotrexate has been used, azathioprine, 6-mercaptopurine, and we then move to TNF inhibitors, although as Dr. Sherrill alluded to, we want to really consider moving away from these. And even though not all of the IL-12, 23 or JAK inhibitors are approved for all different forms of inflammatory bowel disease, we don't want to rely exclusively on TNF inhibitors. As rheumatologists, as opposed to the gastroenterologists, where you have widespread inflammation in the gut, if we see limited number of joints, we can inject those with corticosteroids directly with long-acting, long deposit corticosteroids that should stay in the joint for a long period of time, we hope. Sometimes we give a short course of oral medicines or an intramuscular injection of oral glucocorticoids. We try to not use them long-term, but more as a bridge to therapy until we can get relief from the DMARD, disease-modifying antirheumatic drug, or the biologic agent, as Dr. Sherrill alluded to. We do like to refer all of our patients to physical therapy for back exercises that will sometimes help the pain, but also we want to improve the posture and try to maintain the range of motion as much as we possibly can to prevent fusion. So I'll stop there and turn it back over to the 92NY team, and look forward to further discussion with Dr. Sherrill and others.
Thank you so much for that, Lou. And I'm bringing Ellen back in here. So I'm going to give you about 5 or 6 minutes to have a back and forth discussion. And then we have a lot of really amazing questions coming in. So I want to make sure we leave plenty of time for those.
So Ellen, I'll ask Ellen, where do you see the IL-12, 23 inhibitors and the JAK inhibitors moving up into the treatment of IBD, because we use a lot of JAK inhibitors now for rheumatoid arthritis, and for seronegative, it's moving up. And the same with, you mentioned, Tremfya will be soon approved, which is approved also for psoriatic arthritis. So how do you see the therapeutic armamentarium changing over the next year or two?
I think that in terms of algorithmic medicine, we're moving away from the era in IBD of first-line anti-TNF. And I think the IL-23s are going to move even ahead of the IL-12 23s. We'll see. We're still waiting for head-to-head comparison of those two. But those are not immunogenic. They don't have a black box for infection and lymphoma risk. We don't have to talk about combination therapy to lower the immunogenicity. So I think those should be first line. Similarly, for the JAK inhibitors, it's impressive because it's a 1 pill a day, but it does have a black box. It's still immune suppressant, but incredibly effective for some of these patients who are on the launching pad for surgery for colitis. And also because we did the study in Crohn's, very effective. It was the selective JAK inhibitors, such as upadacitinib. Ozanimod is going to play a role, same thing. It's a once-a-day pill with no black box. I think it should be used for first line for ulcerative colitis, and when it's approved for Crohn's disease, first line. We can always go to the TNF, but remember, in all the control trials, maintenance, 50% of patients who responded lost response at the end of the year due to the immunogenicity. So we have a lot more maneuverability, stopping and starting the medications with these other 3 classes, and more to follow.
Yeah, that's great. Just a word about biosimilars. So, for the TNF inhibitors, some of them are coming off of the patent, and there's more and more biosimilars coming on the market. I think that from the rheumatology point of view, the diseases for which the TNF inhibitors are approved, the biosimilars generally tend to be very effective. The FDA has created a separate pathway for approval of biosimilars that doesn't require all the clinical testing in every disease indication. But I think that there can be potential for a lot of confusion among patients who, if there's 5 different types of infliximab made by different companies, sometimes they're switching around frequently. But I did want to bring that up because it does influence the way that our patients see the TNF inhibitors. I agree completely with what you said about the coming trends for IBD. And in fact, with arthritis, I think we're starting to see other drugs kind of move up the chain. The initial therapy for many years was methotrexate, and then TNF inhibitors were the only biologics we had. And so out of a lot of historical precedent, they were the first line of therapy for inflammatory arthritis. But I think now other drugs are starting to move up. So I appreciate your comments on that too.
And I also think that patients want to know how to position diet and nutrition. The anti-inflammatory diets work for IBD, but also for arthritis. When they're really sick, the diet alone is not going to help. But as they get better, I think that's something that we work very closely with our nutrition team. And there's a link to some of our nutrition approaches. What is your approach with to patients for rheumatoid arthritis and the other arthritides in terms of diet, lifestyle?
Yeah. So I think there's a little less known about diet in rheumatoid arthritis. It doesn't have the gut connection. In the past, dietary studies, well, first of all, in general, diet studies are extremely difficult to perform because you have to have detailed diet histories. If you rely on recall, they're notoriously incorrect. And it's also kind of hard to interpret everything. So I think there's much more data in gut disease. The influence of the microbiome, for example, is really important, but we're just really starting to scratch the surface. So for rheumatoid arthritis, I don't really have any specific advice on which diets to use. We have a lot of patients who anecdotally tell us if they avoid certain foods, they do better. If they eat certain foods, they do worse. So we unfortunately don't have a lot of data. We take a very pragmatic approach and say, follow the N of 1, what works for you, continue to do that and eat a nutritionally balanced diet. For rheumatoid arthritis, before we had good treatments, people would go on grapefruit diets and all kinds of exclusionary diets and unbalanced diets. So in general, we tell people to eat a balanced diet, but follow reason and caution. And if there's certain foods that trigger, they should avoid them.
In IBD, we're also concerned about some micronutrient deficiencies and vitamin deficiencies, which is why nutritional consultation with a 5-day food diary is so critical. I do want to, one of the references that I have is Dr. Antonio Gatto, who was the dean at Cornell. Some of his original work was Shea Eddy, which was food for hypercholesterolemia and heart problems. And he tells the story on YouTube of talking to Dr. DeBakey saying, look, I think cholesterol has something to do with all this heart disease. And DeBakey said, no, none of our patients have elevated cholesterol. And his question was, what was your level at your cutoff? And it was 300. We now know that, of course, we are aiming for less than 150 for cholesterol. But similarly for IBD, and I think for the arthritides, these high-fat diets that drive inflammation is the first thing to go, and sugar is the second thing. And then there's a reference to Richard Lustig's book, Metabolical, which is all about processed food. So I guess the question that I have for you, Lou, is, we have our disease activity index. At the end of the day, we give 1 point if a patient complains of joint. So we're missing a lot of inflammatory arthritides and other arthritides. How do you think your scoring system works for missing or capturing IBD in the arthritis world?
Well, that's a really good question. So I think that what we need to do is incorporate that, first of all, into our history, our standard history, to talk about GI symptoms. But most of our scales don't have gut symptoms in them. So obviously, if someone has IBD associated arthritis, we would ask about it. But a lot of our outcome measures are restricted to the joints. And I think, as you just said, we're missing a lot of GI symptoms that, unless we ask specifically as part of our history, they're not included in our disease activity scores. So I think that's a really important point.
I think a lot of opportunity for collaboration in addition, clinical as well as science.
Yes.
Thank you so much for that. Well, again, we have so many amazing questions coming through. I want to make sure we get to as many of them as possible. So let's kickstart this with, please tell us more about leaky gut and its relationship to lactose intolerance.
So let's talk about leaky gut. Yeah, I showed you that epithelial cell layer. That is supposed to be as not porous as possible, so that the bacteria don't leak into the deeper layers of the tissues. And I think when there's inflammation, there becomes a loosening of those cell-to-cell junctions, so bacteria can flow easily into the gut and cause chronic inflammation. And in addition, there's proteins that leak out. So we talk about a protein losing enterocolopathy. And that's one of the reasons that a short course of steroids for several months seals up those leaks, so that when we give you effective therapies, the medicines stay in the system and in the gut instead of being lost into the lumen and getting eliminated. So leaky gut is independent of lactose intolerance. It's part of the inflammatory spectrum of disease. Needs to be controlled before the medicines can be optimized. In terms of lactose intolerance, mostly that's for gas, cramping, bloating, diarrhea. So it interferes with our symptom evaluation, because those are non-inflammatory symptoms. And I don't believe that leaky gut is really part of lactose intolerance.
Thank you. And Dr. Bridges, we have someone who's interested in how to treat basic osteoarthritis in the absence of Crohn's.
So, so osteoarthritis, we've evolved our thinking over time. It used to be referred to as simply degenerative arthritis wearing out of the joints. We think of it more of the joint and the surrounding structures as an organ, because you have muscles, tendons, ligaments, meniscus, all sorts of things in there. But in general, and we also used to think it was non-inflammatory, but some of the more recent work in the last decade has shown that there's bone marrow edema underlying some of the osteoarthritis lesions. But in general, we don't see the degree of inflammation in osteoarthritis that we do in the autoimmune inflammatory types of conditions that we're talking about with Crohn's and colitis and seronegative spondyloarthropathy and rheumatoid. So the treatments tend to be more, and what the single biggest need that we have in rheumatology as a specialty is a way to treat or reverse or cure osteoarthritis, because it's so difficult. And the factors that cause it include, in the hips and the knees, particularly obesity, abnormal gait, damage to the cartilage with injury, malalignment. So there's so many factors. Nutrition plays a role. So that's our single biggest need. Unfortunately, right now, the way we treat osteoarthritis is to cover the symptoms up. And when it gets really bad, we can inject corticosteroids or other substances in there to try to help. The hip and the knee, at HSS, Hospital for Special Surgery, we do about 1% of all the knee replacements in the country are done at our institution every year, which is a massive number, 15 or 20,000 a year we do. So that's not a good way to, treat a disease, but it is effective if there's destruction of the joint. One of the things we pin our hopes on and hope desperately we can get to is regenerative medicine. You hear a lot about stem cell therapy. Stem cell therapy, for the most part, is not really ready for prime time. Athletes who have one specific area of the joint that might be damaged might do better with platelet-rich plasma or stem cell therapy or autologous cartilage transplant, where you grow cartilage in a petri dish and then implant it into the specific area where there's loss of cartilage. But in general, the biggest hope that we have for the future, I think, for osteoarthritis is regenerative medicine, as opposed to the inflammatory arthritis that we talked about before, where we use a lot of drugs targeting, they're either small molecules that target inflammation pathways or biologics that target specific pathways.
What about vitamin D level? We're very aware of vitamin D is actually low vitamin D being associated with increased inflammation in the gut, but also being a precursor for osteopenia and osteoporosis, partly related to malabsorption and decreased intake. I'm interested in your comments.
Yeah, so so the vitamin D, there's been a tremendous amount of data coming out about vitamin D. And there are a lot of data that show that it's linked to inflammation, as you just alluded to. From the point of view of rheumatoid arthritis, what we try to do is to keep people's levels at least 30 to 40 with as much calcium as it takes to get there. The other point I'll make is that supplemental calcium is great, but we really prefer people to get calcium through their diet. And the same with vitamin D. You can supplement as you need it, but calcium in particular, we prefer to get it through the diet, and to prevent osteoporosis or thinning of the bones, which is different from osteoarthritis. To prevent osteoporosis, we want to make sure there's good calcium and vitamin D intake. And vitamin D supplements are generally very effective at keeping people above 30 or 40 if people can't get sufficient levels through their food.
Yeah, and the calcium, brings up the downside to having too much calcium. You need to work with your cardiologist as well. So what's good for the gut turns out to be good for the heart and the bones and the joints. So it's a multifactorial approach. There was a question about stem cells. So stem cells, we are doing studies now looking at stem cells being injected into fistula and healing the fistula. Where they will go in terms of infusion therapy remains to be seen. This autologous T cell transfer is an infusion, but again, it's, as soon as the infusion is done, the patient's inflammation recurs. So we have not yet figured out through stem cell or T cell transfer how to turn off the immunostat. And again, we come back to effective therapies, early intervention, and understanding more about nutrition and exercise.
Thank you for that. We do have some questions coming in about the drugs that are prescribed. So one is, please discuss the side effects and risks of treatment for UC drugs particularly, and for those with multiple allergic reactions to most of those drugs.
So for UC, the drugs are very similar to Crohn's disease. Remember, ulcerative colitis was approved for anti-TNF infliximab about 10 years after it was approved for Crohn's disease. And what we learned with infliximab and the other anti-TNFs is that you don't take it regularly, you increase the antibodies, you have an immune response, you lose response, but sometimes you have an allergic reaction. So I would think that most of the allergic reactions were from early use of infliximab or not using it regularly. The anti-IL-12, 23s and 23s alone, we're seeing less and less in ways of allergic or immune responses. They're well tolerated. Infection is not a problem. We talked about lymphoma, a risk for Crohn's therapy, as well as ulcerative colitis therapy. The big thing for ulcerative colitis is now the introduction of the JAK inhibitors, and specifically the selective JAK inhibitors, which we do have to be careful because it has a black box. Need to be treated for and make sure that you get your Shingrix so you don't develop herpes zoster. Less than 20% occur in TOFA, much less in Boca Rupa, but still those are things that we worry about. Thromboembolic risk, we need to look at your lipid profile. Again, coming back to the gut and the heart, inflammation and lipids and triglycerides. I do refer you to the 1988 book by Gatto and his YouTube. It's all connected, but those are the issues that we worry about and that we are concerned about. So we usually do viral titers. We want to make sure you have not been exposed to tuberculosis. We check your varicella titers, as I just said, and we look at your lipid profile. So those are the major things to be aware of.
Thank you. Dr. Bridges, I believe this one is for you. Is club thumbs in a person with IBD an indicator of future arthritic involvement, or is it unrelated?
Say that again, is what?
Club thumbs?
Clubbing.
Oh, clubbing. Yeah, so clubbing, we generally think of as associated with lung disease. There's hypertrophic osteoarthropathy that we think of clubbing more with lung disease. It doesn't generally correlate that well with inflammatory arthritis.
Right. So we see it in Crohn's rarely, but I think as you're saying, it is not a harbinger or a predictor of more likely extraintestinal manifestations at all.
Right.
Thank you for that. Is there any correlation between, oh, I'm sorry. Any recommendations for seeking relief for pervasive osteoarthritis?
That's a tough one. So the categories of drugs we use include non-steroidal anti-inflammatory drugs. We sometimes use duloxetine Cymbalta, which is an antidepressant, which seems to sometimes help pain of osteoarthritis. We sometimes use drugs if there's some component. We do have pain modulators such as gabapentin, which we sometimes try to use. The local therapies of injections. There are some physicians who give hyaluronate, so injections of hyaluronic acid. Unfortunately, we just don't have great treatments, and chronic pain is really a devastating complication of diffuse osteoarthritis that we do not have good solutions for. So as I mentioned, I hope someday that regenerative medicine will provide us with some answers, but it's very unsatisfying for the patients and for the doctors for the most part. And someone who has diffuse kind of unrelenting osteoarthritis is not a lot of great options.
So much more work to be done.
Yes.
Okay, Dr. Sherrill, I believe this is for you. Could you please advise on suggested approaches as to mitigating IBD and associated bowel issues from a diet standpoint? This audience member knows it's best to reduce sugar and carbs, but what other suggestions do you have in terms of diet?
So we work very closely with Ryan Warren, who is our clinical nutritionist, and there are anti-inflammatory diets that, if strictly adhered to, may be helpful. But it does have to be done with a nutritionist, because if you have a lot of active inflammation, there are foods that are anti-inflammatory, such as high fiber, which you need to avoid. And also, we want to make sure that you're getting your micronutrients and vitamins. But there are strict anti-inflammatory diets. The low carbohydrate diet is one. And so, again, like with all medicines, we ask that you work with a nutritionist trained in this.
Okay, and how long, Dr. Bridges, would you say does it take spondyloarthritis to show up in an MRI?
So if someone has damage, it should show up right away. Inflammation often will show up right away on an MRI too. So if the question is, if you're going to get damage from spondyloarthritis, how long does that take to occur? It's very variable, and not everybody gets severe damage. And in fact, we try to treat early to prevent it. But if the question is more, if it's present but it doesn't show up on MRI, usually that's not the case. The tests we have now, the imaging we have now with MRI is exquisitely sensitive, and we generally see it. Now, X-ray films are very different. So traditional X-ray films, for example, with any kind of arthritis, it typically doesn't show changes until there's already damage. So that is much less sensitive for picking up damage. But for MRI and some of the newer, really beautiful techniques that they have now, you can pretty much detect inflammation or damage very early.
Is there a role for osteopenia, osteoporosis in the treatment of osteoarthritis?
So it's interesting because osteoporosis and osteopenia, which is a mild, so there's normal slight bone loss called osteopenia and more severe called osteoporosis. Those are all asymptomatic, so they do not cause any symptoms. Osteoarthritis is symptomatic. Interestingly, we did a study showing in our African-American cohort, which we had of rheumatoid arthritis, that low bone mineral density in the hip seemed to predict erosions from rheumatoid arthritis. But that's not been repeated consistently, but it is of interest that if you do have thin bones, you're more likely to, theoretically, you're more likely to have damage from inflammatory arthritis, but it's not really been proven yet. And again, osteoporosis and osteopenia don't cause any symptoms unless there's a fracture.
All right, so we're going to take just one more question out of respect of everyone's time, and then I will go ahead and send out these slides this evening as well to everyone attending. So for mild to moderate Crohn's disease, is it possible to go on a biologic such as Stelara, be in remission for a few years, and then go off the biologic at some point, or do you think it's better as a lifelong treatment?
So of course, that's an individual question. It has to be answered individually, but the thing with the anti-IL-12/23, such as Stelara, ustekinumab, and I believe risankizumab, which will have more data, you can stop and start this. So if you're doing well, you move from every 8 weeks to every 16 weeks to once a year. And then if you flare, you can reintroduce that. We've been using the anti-IL-12/23s since the initial studies when it wasn't even available. And then when it did become available clinically, we reintroduced it without any of the problems of reintroducing infliximab or adalimumab after a long period of not being available. So you have much more maneuverability in terms of stopping and starting. And again, part of that is, what are your symptoms? Is there mucosal healing?
Fantastic. Well, I want to thank both Dr. Lou Bridges and Dr. Ellen Sherrill for their time this evening, for this fantastic information. We did have some questions that we couldn't get to, so I'll go ahead and send those to you. And maybe when I send the recording out to everyone, we can address a few of those questions that came through. But thank you everyone so much for joining us for this Spark Your Health talk with the 92nd Street Y. And I hope that everyone can take this information with them and have a wonderful evening.
Great.
Thank
you.
you.
Hope everyone has a great night. Thanks, Katera.
Katera.
Very welcome.
Good to see you, Ella.